Welcome back. My name is Alina Gonzalez Mayo, and we're going to be now going over the mood disorders. This is the chapter that deals with depression, bipolar disorder, grief, depression, etc. So it's a big chapter. It tends to be very high yield on the exam. So let's get started. Let's begin this chapter by looking at a vignette. A 70-year-old woman was recently admitted after her son informed the doctor that she had been doing very poorly. The patient reports a 30-pound weight loss, decreased concentration, feelings of helplessness and hopelessness, decreased energy, depressed mood, and decreased sleep. We know that this is major depression because one of the features that's essential for major depression is that you have to have a depressed mood, and she has that. Another essential feature is that it has to affect your functioning, and given these symptoms, it clearly is affecting her functioning and the fact that the son is saying that she's not doing well. You also have a series of other symptoms ranging from weight to energy, sleep, etc. For you to have the diagnosis of major depressive disorder, you need to have at least 5 depressive symptoms for at least 2 weeks, and it has to affect your level of functioning. Because of the depression, you're not going to work, you're not going to school, you're doing poorly, you're not hanging out with your friends, you're not eating, you're losing weight, etc. People who have depression wake up depressed, stay depressed, and go to bed depressed. So the symptoms, remember, are bad enough that your functioning is affected. You tend to see more depression in women than you do in men at approximately 2 to 1. The average age of onset is about 40 years, but you can definitely see it in younger than that. People who have depression typically have no one to talk to, no friends, no relationship, and it makes sense. If you're alone, you're more likely to become depressed. They tend to have problems with their neurotransmitters, including norepinephrine, serotonin, and dopamine. And typically these neurotransmitters are going to be found in decreased amounts. Not only are these neurotransmitters found in decreased amounts, but also their metabolites. And the most important metabolite of all will be the metabolite of serotonin, which is 5-hydroxyindoleacetic acid, or 5-HIAA. Now that has been linked to either suicide or aggression. It tends to be genetic, so you tend to be seeing family loading. So mom had it, you might have it. And there's usually numerous stressors that have been linked to depression. For example, death of spouse, death of the parents before you turn 11, among other things. The way you make the diagnosis of depression, remember you needed 5 or more symptoms. These included either depressed mood or anhedonia. Anhedonia was an absence of pleasure. You don't enjoy things like you used to. Patients who have depression feel worthless. They feel hopeless. They feel helpless. They feel guilty. They have problems with shame. They have very little energy, so they lie in bed a lot. They don't feel like going out. They have problems with concentration. So when you do the mental status exam and you do serial 7s or serial 3s, you'll see them performing very poorly. They tend to have problems with appetite. They also have problems with weight. So if your appetite decreases, you tend to lose weight. If your appetite increases, then you can have increased weight. They also have sleep disturbances, whether they're sleeping too much or sleeping too little. About 2/3 of them will have recurrent thoughts of death, and about 15% of them will have thoughts of suicide. So one of the biggest risk factors for depression, of course, will be the suicide. As far as physical evidence for depression, you usually won't see much in the physical exam. You could see some psychomotor slowing. You could see some cognitive impairment, so maybe they're slow to answer questions. You will have problems with concentration. They could be forgetful, and that's why many of them, when they're slightly older, they worry about having dementia when actually what they have is a depression that makes them look like they have dementia. You can also have a depression with psychotic features, which tends to be a worse prognosis. The way we treat these patients is by giving them both antidepressants as well as antipsychotic medications. ECT, or electroconvulsive therapy, has also been effective in the treatment of these disorders. Major depression with atypical features, or as it is called in some books as atypical depression, is an individual who not only has depression, but they are also sleeping more, eating more, and gaining weight. That's what makes it atypical, because typically patients are lying in bed, they're not sleeping, their appetite is down, and they're losing weight. So atypical depression has increased sleep, increased weight, and increased appetite. Another clue that is common in the patients who have atypical features is that they have something which they call laden paralysis, where you feel like your limbs are made of lead. So the patients will complain that their limbs feel heavy. On the exam, usually when you get a question on atypical depression, monoamine oxidase inhibitors, or MAOIs, become the treatment of choice. But this is typically only true for your exam. When assessing patients who have major depression, it is imperative that we assess suicide. So we want to make sure that we assess suicidal ideation, meaning are they thinking about it? We want to make sure that we assess whether they intend to do it, and that would be suicidal intent or suicidal plan, where they actually have a plan. Medication-wise, you would want to give them antidepressant medications where you would prefer to give them the drug with the least amount of side effects. So usually SSRIs or SNRIs, which are the serotonin selective reuptake inhibitors, or the serotonin norepinephrine reuptake inhibitors, are considered to be first line. However, if given the choice, serotonin selective reuptake inhibitors would be the most likely indicated in these patients. And later on, when we go over the pharmacotherapy section, we will go over these medications in detail. Electroconvulsive therapy, or ECT, can be used, but it's basically used today for those patients that are extremely suicidal, where we don't have the time to wait for the medication to be effective. It's also used for those patients where maybe the medication could be more detrimental. Maybe these are patients who have complications where the medications would make it worse. Individual psychotherapy or cognitive therapy are also indicated in the treatment. You will never get a question where they ask you therapy versus medications, since both of them are equally effective. Because this is a medical exam, chances are this is more a question based on medication than types of therapy. So again, SSRIs become first line with these patients. When dealing with patients who have major depression, we want to make sure that we're not missing any medical diagnoses. You never want to be caught saying a patient has depression when actually they have something else. So we want to make sure that they don't have other medical conditions that could give you depression, such as Parkinson's, dementia. Maybe it's problems with the medications. For example, beta blockers can give patients depression. Pseudodementia are those patients who have depression, but they look like they have dementia. Any kind of space-occupying lesions, such as tumors, or even cerebrovascular accidents. But one of the biggest differentials is going to be hypothyroidism. So we want to make sure that we check TSH with these patients. Other psychiatric disorders could be other mood disorders, such as bipolar disorders, substance abuse disorders, or grief. But looking at the cases that are given in the questions will help you determine whether it's a bipolar or a substance abuse or grief. Let's review bipolar disorder by looking at a vignette. A 19-year-old college student is taken to the school counselor after he fails several classes. The patient is enrolled in numerous classes, most of which have conflicting times. His grades are poor, and he seems undisturbed by this. He is also enrolled in numerous organizations, such as the chess club, drama club, student government, sports, and at least 2 fraternities. His speech is pressured, and he has psychomotor agitation. So how do we know that this patient is exhibiting mania? We're going to focus on the age. Notice that he's 19 years of age. You tend to see bipolar disorder in younger patients. The patient also is having pressured speech, where you speak very quickly, and this is seen in mania. Psychomotor agitation is seen in mania. He's involved in a lot of activities, but he's not being productive at any of them. So this is what you typically find in the patients who have mania. And the moment you have mania, your diagnosis becomes bipolar disorder. So let's review this disorder more carefully. Bipolar disorder is a patient who has a mood disturbance for at least 1 week. Now, these symptoms are severe enough that they will cause problems in your level of functioning. So because of the mania, you're not doing well in school, you're not doing well at work, maybe you'll be fired, etc. The mean age of onset is approximately 30 years of age, but it can start as early as childhood. You tend to see more bipolar disorder among the higher socioeconomic status. It is the mental illness that has the greatest genetic linkage. And one of the theories of people who have bipolar is that they engage in what is called the self-medication hypothesis. So they drink or use drugs in order to regulate their moods. So when they're depressed, they might use stimulants. When they're manic, they might use benzos in order to calm themselves down. So there is a high incidence of coexistent substance abuse disorders with these patients. Now, the presentation that you typically find in bipolar patients is that they're going to have an elevation in their mood. They're euphoric, they're on top of the world, they have increased self-esteem, they're grandiose, they're easily distracted, they have psychomotor agitation, so they won't be able to sit still, they have flight of ideas, so they're going from one topic to another, they're going to be talking very fast, and that is called pressured speech, their libido is going to be up, and they have an increase in goal-directed activity. Even though they're not functioning, they perceive themselves to be doing very well. So it's very rare for patients who are in a manic episode to seek treatment on their own. They typically will not, because they feel they are being productive, they feel that their creative juices are flowing, so they're usually brought in to the doctor or to the hospital by family, friends, or even at times the police. When you're dealing with bipolar patients, you will probably see them seek help on their own when they are depressed. When they're in the depressive part of their illness, they're feeling helpless, hopeless, and suicidal. But when they're manic, they tend not to seek help on their own. It doesn't mean they never do, but typically they will not. When treating the patients who have bipolar disorder, we want to make sure that they're safe. We want to make sure they're not suicidal or homicidal, because that will determine whether we treat them as an inpatient or as an outpatient. We will provide pharmacotherapy in the form of mood stabilizers like lithium, valproic acid. Antipsychotics can be used, whether they're typical or atypical agents. Individual psychotherapy can also be used. However, pharmacotherapy is probably what they will be asking on the exam. These drugs will be discussed in detail in the psychopharm section. One of the biggest differentials for bipolar will be schizophrenia. The reason being is that patients who have mania, more than half of them will exhibit psychotic symptoms, whether it be hallucinations or delusions. However, patients who have schizophrenia typically do not have an overriding mood component as you do find in patients who are bipolar. Also, infections, anything affecting the brain can also cause disruption and give you this bipolar-like presentation. One of the changes that was seen from DSM-4 to DSM-5 is in the name of dysthymia. Dysthymia, as you know, was a lower level depression that typically lasted more than 2 years. In DSM-5, this is now called persistent depressive disorder. So let's review a vignette. Mr. Smith complains of poor appetite, low energy, poor concentration, and difficulty in making decisions, which affects his ability to complete his assignments at work. These symptoms have occurred for more than 2 years. The hallmark of persistent depressive disorder is the time frame. So typically these patients have this lower level depression, which can affect their functioning not to the degree of a major depression, but it's the chronicity. The natural course of major depression is approximately 1 year. Patients tend to get better. In persistent depressive disorder, the symptoms are occurring for 2 years or greater. The hallmark of persistent depressive disorder is that you have a depressed mood lasting most of the day and is present for most days for at least 2 years. As mentioned earlier, this was previously called dysthymia. You tend to see it more frequently in women, usually under the age of 64. They tend to be unmarried, probably come from low-income families, and maybe have other psychiatric disorders such as anxiety or any drug-related disorders. The differential diagnosis for persistent depressive disorder is no different than that for major depression. The treatment for persistent depressive disorder is usually individual psychotherapy. However, if psychotherapy is not effective, then you would recommend pharmacotherapy, and it would be the same things that you would use in treating patients who have depression, and that would be the SSRIs, or the serotonin selective reuptake inhibitors, the SNRIs, or the serotonin norepi reuptake inhibitors, tricyclics, or MAOIs. However, because of the side effect profile, we would probably use the SSRIs more than anything else. And remember, this will be discussed in detail in the psychopharm section. Because these patients typically do not have functioning that's severely affected, and usually are not suicidal, hospitalization is usually not indicated in these patients. Now let's review cyclothymic disorder and look at a vignette. Mrs. McDonald has experienced a 12-year history of periods of feeling great, followed by periods of feeling lousy. During her feeling great period, she experiences increased sexual drive, euphoric mood, and increased irritability. During her feeling lousy periods, she experiences insomnia, fatigue, and low self-esteem. So what we have here is a diagnosis of cyclothymia. Why? Because cyclothymia is a patient who has episodes of hypomania and mild depressive disorders that have been occurring for more than 2 years. She's been feeling like this for 12 years, so you definitely meet the criteria. Increased sexual drive, euphoric mood, and increased irritability are symptoms that are not severe enough to be classified as manic. Insomnia, fatigue, and low self-esteem are symptoms that are not severe enough to be classified as major depression. So when you have milder symptoms for a prolonged period, it is called cyclothymia or cyclothymic disorder. Cyclothymic disorder is that individual who has numerous periods of both depressed and hypomanic episodes for at least 2 years in adults and 1 year in children and adolescents. You see this disorder more frequently in women. Usually these patients also have interpersonal conflicts, such as marital problems, boyfriend-girlfriend problems. There tends to be a genetic loading, so you may see a family history of bipolar. Many of them use substance abuse, just as you would see in the patients who have bipolar, and it may coexist with the borderline personality disorder. Looking at differential diagnoses for cyclothymia could be disorders such as seizures. For example, there are many patients who have temporal lobe seizures, and those symptoms can mimic mood disturbances. Substance abuse disorders could also mimic mood disturbances, as well as side effects from certain medications. For example, beta blockers can give you depression, etc. Personality disorders can also be a differential diagnosis. When we're looking at treatment for cyclothymia, psychotherapy tends to be first line. If psychotherapy is not enough, then we would use mood stabilizing agents or mood stabilizers such as lithium or valproic acid. Let's review the major depressive disorder with seasonal pattern, which some of you might know as the seasonal affective disorder. A young woman from Minnesota complains of depressed mood and sleep disturbances every winter. Her symptoms resolve in the spring and the summer. What's unique about this vignette or these types of patients is that they'll probably describe patients who live in the northern states. These are states when it's winter, it gets dark very early. And in the summer, when the days are longer, then their mood symptoms improve. So the definition of major depressive disorder with seasonal patterns is the presence of depressive symptoms during winter, which are again absent during the summer. They believe that this is due to a problem in the metabolism of melatonin. The treatment of seasonal pattern major depressive disorder is bright light therapy or phototherapy. So you have to look at this light that triggers a reaction in the retina, which causes the effects with the melatonin. If bright light therapy is not effective, then by all means, you can definitely try using medications, and SSRIs have been used in these instances. But overall on the exam, bright light therapy is the number one answer. A very important feature of this exam is that you understand the basic difference between grief and depression. You also need to understand that these are two disorders where the symptoms can be similar. Another word for grief is bereavement. So when we look at the symptoms for both grief and depression, we find that they're identical. These are patients who've experienced a loss. Someone has died. So it's normal to have sadness, be tearful, have very little sleep, have very little appetite, have very little interest in things. However, when you're grieving, you tend to have good days and bad days, so your symptoms are waxing and waning. When you're grieving, you don't feel as much shame and guilt. You don't talk about suicide. You don't actually have plans for suicide. And the symptoms can typically last up to 1 year. Most of these patients return to their baseline level of functioning within 2 months, but remember, it can last up to 1 year. You do not provide pharmacotherapy with these patients, so the treatment is usually supportive therapy, maybe going to a widows or widowers group. However, patients who have depression, their symptoms are ongoing and unremitting. They tend to feel guilty about the death, feel shame. They do talk about suicide. And not only do they talk about, but they're serious. They actually have intent. They might actually plan it out. The symptoms continue for more than a year. They basically do not return to their baseline of functioning unless treatment is offered. So antidepressants are needed in the treatment for depression. Now let's review the mood disturbances which occur after women have given birth. We're looking at 3 possible disorders: the postpartum blues or the baby blues, the postpartum depression, and the postpartum psychoses. Typically, postpartum blues or the baby blues are not seen in the DSM-5, but I would expect that they still would ask these questions on the exam. What is the difference between the blues, the depression, and the psychoses? Normally, these are women who either have hormonal imbalances, so you're going from pregnancy hormone to non-pregnancy hormones, or maybe these are women who have underlying mood disturbances or psychotic disturbances. So the stress of the pregnancy, the stress of the delivery can trigger these disorders to appear. The baby blues usually is hormonal induced. You can have that with any one of the babies that you deliver. So it can occur with your first baby, your second baby, etc. It usually begins right after birth, and it can last anywhere up to 2 weeks. These women can have mild symptoms. Maybe they're teary, maybe they can be irritable at times, but they would never consider hurting themselves or the baby. Because they believe this is most likely due to hormones, the treatment is self-limited and no medications are provided or offered. Postpartum depression and postpartum psychoses are different disorders. These are women who might have an underlying depression or major depression, or might have underlying bipolar disorders or schizophrenias. In DSM-5, postpartum depression is now basically called major depression with postpartum onset, where the most recent episode occurred during pregnancy, as well as in the weeks following delivery. I don't see that this would cause confusion when you're taking your exam. So typically postpartum depressive patients will have symptoms that will usually begin within a month of delivery, and the symptoms may continue. The type of symptoms that you'll experience will be depressive symptoms: sleep problems, energy, concentrations, hopelessness, helplessness. Because the mothers are depressed, they're at risk of hurting themselves and possibly at risk of hurting the baby. However, more times than not, the mothers do not kill the babies. Because we're dealing with underlying major depression, then you will treat it just like you would major depression, and that would be with antidepressant medications. And remember, if we're focusing on side effect profile, then the SSRI would be our go-to drug. If we're dealing with postpartum psychoses, maybe these are women who have underlying bipolar or underlying schizophrenia. The symptoms usually will begin within a month, and they may continue. So these women can not only have mood symptoms, but they also have psychotic symptoms. They can have hallucinations, they have delusions, they believe that the baby is possessed, they can believe that the baby is the Antichrist. So therefore, they can have thoughts of hurting themselves, or if they believe that the baby is the Antichrist, they may have thoughts of hurting the baby as well. The treatment for these patients would be give them either mood stabilizers, antipsychotics, or even antidepressants with mood stabilizers or antipsychotics. But definitely, an antipsychotic has to be on board. Postpartum psychoses can be seen as a psychiatric emergency only because these women are at increased risk of killing their babies. So they're more likely to do it as opposed to the postpartum depression mothers. So our first job is to ensure that this mother does not have access to the baby. So therefore, you would want to hospitalize a mother to make sure that they're both safe. Once the mothers return and they're on medication, then of course breastfeeding should not be recommended, since these medications can be transmitted in the milk. Stages of death and dying, according to Elizabeth Kubler-Ross, are important for various things. One of them being that they're not specific for death and dying, and the other one, of course, is that they don't have to go in a specific order. There are 5 stages. I recommend that you learn the stages in order, but also understand that they don't have to go in order. Stage 1 is shock and denial, where you've just been told you have an illness. So your first response might be, the doctor made a mistake, I want a second opinion, or maybe I want another biopsy. Stage 2 is where you're now angry with your diagnoses. Stage 3 is where you are bargaining. You might become hyper-religious. You might start making promises. Stage 4 is depression, where you go through signs and symptoms of depression. And stage 5, of course, is acceptance, where you understand your fate. You might write a will, take care of everything before you die. A common question that gets asked in these stages is where they'll give you a scenario and then they'll want to know which one of the stages can occur first. One of the choices that typically will be given is any of the above. That's always a better answer than picking shock and denial as the first stage, since remember, they don't have to go in any order.